Picture this. You're standing right there at a patient's bedside. Your hand presses deep into the left upper quadrant of their abdomen, and you immediately feel a distinct, solid mass. Now, before you say a single word to the patient, you need to answer one absolutely crucial question correctly in your own head. Because if you get it wrong, you might spend the entire patient encounter chasing the completely wrong diagnosis. We're talking about hepatosplenomegaly today, and in this explainer, we're going to build a rock-solid mental framework from first principles. That way, you'll never get lost in the diagnostic weeds again. So back to that mass under your hand. Is it the spleen or is it a kidney? I know, it sounds almost basic, right? But getting this initial question wrong means you're suddenly heading down a nephrology differential when you really should be exploring a hematology-oncology one. You literally take a wrong fork in the road. One path leads you toward leukemias and lymphomas, while the other takes you toward kidney pathology. So how do you know? Well, think about the spleen first. When the spleen enlarges, it grows diagonally, kind of pointing from the left costal margin straight down toward the right iliac fossa. It's dull when you percuss it, and crucially, this is the big one, you cannot get your hand above it. An enlarged kidney, though, behaves completely differently. For one, it's palatable, meaning it actually bounces between your two hands when you palpate. The percussion note for the kidney? It's generally resonant. Why? Because you've got bowel gas sitting right over it anteriorly. Plus, you can often feel its top edge and actually get your hand above it. Now grab this number and hold on to it. 3. 3 times. A normal spleen only weighs around 150 grams. For you to even feel it slipping under the costal margin, it literally has to triple in size. So the takeaway here is that by the time you can actually palpate a spleen at the bedside, something has already been driving a genuine, significant pathology for quite a while. A palpable spleen is never just a minor blip. So, our roadmap for this explainer. 1. Shared mechanisms. 2. Massive splenomegaly. 3. Infiltration focus. And 4. Post-splenectomy guidelines. All right, section 1, shared mechanisms. One process or two? Here's a mental model that's going to save you so much time. Liver and spleen enlargement can result from two completely separate coincidental diseases. But much more often, and much more helpfully for us, it's from one shared upstream process driving both of them at the exact same time. The first major shared mechanism is portal hypertension. Think of it like a plumbing issue. Cirrhosis or Budd-Chiari syndrome raises the pressure in the portal venous system. That high pressure has to go somewhere, so it backs up and it engorges the splenic vein just as much as it engorges the liver itself. It's one mechanical pressure issue causing two enlarged organs. The second shared mechanism is infiltration. This is where a single, sneaky disease process, we're talking malignant cells, storage material, or infectious organisms, deposits pathological material into both organs simultaneously. And why both? Well, because the liver and the spleen share a common physiological day job, filtering and processing the blood. That shared job makes them natural, simultaneous targets for whatever pathological material happens to be circulating. So please, do yourself a favor and don't try to memorize some giant, impossible laundry list of individual diseases. Map them out by mechanism instead. Myeloproliferative and lymphoproliferative disorders, they infiltrate both organs with abnormal proliferating blood cells. Infections, everything from hepatitis to malaria, they enlarge both organs through immune activation or direct infiltration. And then autoimmune and metabolic diseases like sarcoidosis or Gaucher's, they deposit abnormal accumulated material. When you categorize everything by mechanism, this massive differential suddenly becomes incredibly manageable. Moving on to section 2, massive splenomegaly, the filter. Now, we need to be really precise about what massive actually means in this context, because it's not just slightly big. We are talking about a spleen exceeding 1,000 grams, measuring over 20 centimeters on imaging, or physically extending all the way down into the left lower quadrant, or even crossing the midline of the abdomen. Recognizing this specific size criteria is a total game changer for how you approach the patient. Why does it matter so much? Because the second you hit those massive criteria, your differential completely collapses from dozens of vague possibilities down to a highly specific, exclusive shortlist. Chronic myeloid leukemia, myelofibrosis, visceral leishmaniasis, malaria, and Gaucher's disease. Every single clinician should have this exact list locked in their memory. If it's massive, your thinking narrows directly to this handful of diagnoses. No exceptions. Section 3 now. Infiltration focus, pattern recognition. Let's take Gaucher's disease as our textbook example of infiltration. It's one of those diagnoses that is so easily overlooked, especially in young patients. It's an autosomal recessive, lysosomal storage disease driven by one deficient enzyme, glucocerebrosidase. Because of this deficiency, a substance called glucosylceramide just endlessly accumulates inside macrophages. And remember, the reticuloendothelial system of the liver and spleen, it is absolutely packed with these macrophages. So they both swell up at the same time. Clinically, you're going to see a young patient with fatigue, growth retardation, and these incredibly painful bone crises. Why the bone pain? Because that exact same infiltrative process is also stuffing the bone marrow. And here is the amazing payoff for identifying this exact first principle mechanism. We don't just throw generic symptom management at them. We actually have a highly targeted treatment. Enzyme replacement therapy with recombinant glucocerebrosidase is first line. We literally just replace the missing piece of the molecular machinery. It's incredible. Okay, let's pivot to another classic named pattern, primary myelofibrosis. This one is probably the single most common cause of genuinely massive splenomegaly you're going to see in clinical exams. It's driven by a failing, fibrotic bone marrow. Because you have this totally ineffective erythropoiesis going on, the spleen desperately tries to compensate. It tries to take over blood production, and it grows completely huge in the process. You'll see a pale patient with massive splenomegaly, and their blood smear will classically show these little teardrop cells. If you attempt a bone marrow biopsy, you'll likely hit a dry tap because the marrow is just so fibrotic. Genetically, you're looking for JK2, KLR, or MPL mutations. Then there's polycythemia vera, or PV. These patients have a completely different visual vibe. They present with a plethoric, meaning a deeply reddened face, conjunctival injection, and an enlarged spleen. This one is caused by a clonal overproduction of red blood cells, almost always linked to a JAK2 V617F mutation. But here's the most fascinating, bizarre clinical symptom for PV. Generalized pruritus, or severe itching, which classically gets way worse right after they take a hot bath or shower. And that actually brings up a golden clinical rule. Whenever a patient presents to you with generalized pruritus, you should instantly lock in on 3 leading diagnostic suspects: primary biliary cholangitis, polycythemia vera, and cholestatic jaundice from some other cause. Applying that kind of diagnostic logic rapidly takes you from a super vague symptom down to a concrete, actionable differential. All right, Section 4. Post-splenectomy guidelines. Life after spleen. Because living without a spleen, it brings a very elevated, very specific kind of danger. Patients face a complete loss of the normal clearance mechanism for polysaccharide-encapsulated organisms. Normally, the spleen acts as the ultimate filter and antibody factory to fight off these specific bacteria. Without it, patients face a severe, life-threatening risk of overwhelming infection. To manage this safely, we absolutely have to follow the updated 2024 British Society for Haematology guidelines. They map out a strict, multi-pronged prevention package. Step 1, specific vaccinations. We're talking pneumococcal, Hib, meningococcal, and of course, the annual flu shot. Step 2, long-term prophylactic antibiotics. And Step 3, which is honestly perhaps the most vital of them all, rigorous patient education on seeking immediate, urgent care for literally any febrile illness. They cannot wait it out at home. Honestly, this requires a total mindset shift for a lot of practitioners. It is a genuinely lifelong risk that deserves active, ongoing counseling rather than just a one-time vaccination at the time of surgery. You don't just give them a shot before they discharge and wave goodbye. You're actively managing and counseling their post-splenectomy status for the rest of their life. Okay, let's pull this whole thing together. Let's look at the diagnostic funnel we've built from the ground up today. First step, confirm the organ at the bedside. Are you feeling a dull spleen or a resonant palatable kidney? Second, identify if there's a shared mechanism driving the enlargement. Is it portal hypertension or is it infiltration? Third, filter by size. If that spleen is massive, immediately apply your specific 5-disease shortlist. And fourth, look for those named patterns in the patient's face and history, the bone crises of Gaucher's, the teardrop cells of myelofibrosis, or that crazy hot bath pruritus of PV. So I'm going to leave you with this. The next time you're at the bedside and your hand finds an enlarged organ in the upper abdomen, are you just going to stop, shrug, and shout, hepatosplenomegaly, needs workup? Or will you apply these first principles, use the size, the mechanisms, and the clinical patterns, and confidently diagnose it before the first blood test even comes back from the lab? Thank you for joining me for this explainer, and as always, keep asking the right questions.